Hi, everyone, and welcome to the Parkinson's Foundation's PD Health at Home Wellness Wednesdays. I'm so grateful that you are here. Today's PD Health at Home Wellness Wednesday webinar offers an introduction and basic overview of Parkinson's disease. PD varies from person to person and changes over time. We will explore its causes, the common symptoms of Parkinson's disease, available treatments, and effective strategies for managing the symptoms of PD. We'll also learn practical daily living tips to empower you to take charge of your health and to navigate the challenges of living with Parkinson's. We want to thank today's webinar sponsor, Biogen, for supporting the mission of the Parkinson's Foundation. Thank you, Biogen. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, EP Salud en Casa. Be sure to visit our website by scanning the QR code to see what's coming up and explore our archive videos on YouTube. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day. And now it's my pleasure to introduce our facilitator for today's session. Dr. Aditya Vikram Boddu is a movement disorder specialist and assistant professor of neurology at the University of Arkansas for Medical Sciences. Originally from India, he completed his medical degree at Gandhi Medical College before moving to the United States for a neurology residency at the University of Missouri, where he served as chief resident. He went on to complete a fellowship in movement disorders at the University of Alabama at Birmingham as an Edmund J. Safra Fellow. Today, he's part of the UAMS Movement Disorders team, where he cares for patients, trains future doctors, and conducts clinical research. Dr. Boddu, thank you so much for joining us today.
Thank you very much for that kind introduction, Krista. It's really a pleasure and an honor to be here, to be able to share my thoughts on Parkinson's disease with this wide audience. It is really heartening to see all the participants on this webinar today. So let's begin, and I'm going to try to share my slides here. These are my disclosures. And these are the learning objectives for today. We're going to learn what causes Parkinson's and who gets it, understand the common motor and non-motor symptoms of the disease. We're going to talk about treatment options, particularly exercise, the importance of having a good care team, and learning a little bit more about resources and support. So this is a narrative structure where we'll be talking about some of these concepts. And I'd like to see again if I can just present this in presenter mode.
Oh, are you having trouble seeing your slides, Dr. Boddu?
Yes.
Okay. We can see them just fine here. So let's try just hitting the escape or ending your slide share. And then let's restart. Yeah, there we go. Let's see how that works.
Okay.
Can you see them well?
Yes, that's much better.
Great.
I hope it's working out for you.
Yes, it looks great.
Okay, so why are we here, and why should we be paying attention to Parkinson's disease? Why should we care about this at all? In part because it is a very complex disease that affects patients who have Parkinson's, but also their caregivers and families, but also because the incidence of this disease seems to be increasing quite a bit. So the estimated number of Parkinson's patients in the world was 2.5 million in 1990. And this figure has more than doubled to 6 million people in 2016. This was according to the Global Burden of Disease study, which was about 10 years ago. Now, it's projected that by the year 2050, there's going to be about 25.2 million people living with Parkinson's. When it comes to the United States, current estimates place more than 1 million Americans living with Parkinson's. It's also one of the world's fastest growing neurological diseases. And it seems to be in part because its prevalence increases sharply with age. And when you think about the economic impact of this, its burden is estimated to be at least about $50 billion per year in the United States alone. Now, in the figures here, you see the prevalence of Parkinson's. In the figure on the right, you see that Parkinson's tends to be a bit more common in males in the red curve compared to females in blue. And there seems to be an inflection point with advancing age, as aging is a risk factor for this disease. Now, though not infectious, Parkinson's exhibits several characteristics of a pandemic. It is something which extends over large geographic areas, and it's increasing in every major region of the world. This pandemic seems to be fueled by aging population, increasing lifespans with people living longer, and also the longevity of those living with Parkinson's. It's also, unfortunately, one of the consequences of living in an industrialized world that does not seem to prioritize action against environmental issues. So although the descriptions of Parkinson's have existed in Asian cultures, it was in 1817, so that's slightly about 200 years ago, that James Parkinson, a London physician, published his essay on the shaking palsy. So in his monograph, he talked about 6 cases where he presented this chronicle of physical decline, from which he developed a history and theory of the disease. His monograph continues to be acclaimed for its clarity of description and originality of thought. And then it was several decades later, in the late 1800s, that Charcot, the French neurologist, suggested that this disease be named after James Parkinson, who first described these cases. He also alluded to the fact that Parkinson's is a very visible disease. So Charcot talked about seeing such patients everywhere on the streets of several European cities, where the clinical picture could be identified from a distance. Now, patients who may have Parkinson's often wonder about what were the first signs of this disease. And that can be actually quite difficult to tell. In fact, Parkinson himself talks about so slight and nearly imperceptible are the first inroads of this malady, and so extremely slow is its progress that it rarely happens that the patient can form a recollection of the precise period of its commencement. And although most cases may become apparent by the presence of a tremor on one side of the body, such as the hand or the foot when the body part is at rest, tremor is not really a universal feature. In fact, some cases of Parkinson's never really have tremor in them. And in retrospect, patients often wonder about what the actual onset was. So these are some patient-reported symptoms that I've learned from over the few years, which seem to be interesting onsets of presentations of the disease. So one of them was an auctioneer who had to retire in his early 50s because he found that his voice was becoming softer and he was not able to project his voice and yodel things to his audience. There was also the case of the man who found it difficult to tango with his wife at dance lessons because he just couldn't keep step with the timing and the rhythm with his foot. Then there was the long distance runner who found that midway through his 10K run, his foot would always turn in and become kind of stiff and painful. The avid hiker who, after several decades of hiking, found it weird that he kept tripping and falling over tiny twigs and roots. These are some of the more uncommon cases. However, common things which patients find are that the handwriting size may decrease the longer they write and become illegible. Shoulder joint stiffness on one side of the body, which may persist despite treatments, is another common symptom. And often it's the family who may notice that someone may be walking slowly without swinging their arms and having more troubles with balance, which leads to a patient coming to a neurologist. Now, while Parkinson's is twice as common in men, and all the 6 original cases in James Parkinson's essay documented the experience of elderly males, it is very important to note that Parkinson's can really affect anybody. It can affect all people of all sexes, races, and ages. And so the public assumption that this is a disease of old people is not really true, and unfortunately can lead to delays in the diagnosis. It's also important to understand that the experience of Parkinson's is unique to each and every patient, and it really has a very wide clinical spectrum. And segueing from that is just a figure from adapted from nature, which shows the wide spectrum of symptoms that somebody with Parkinson's can have. So a clinical diagnosis of Parkinson's occurs with the onset of motor symptoms, but these can often be preceded by several non-motor symptoms, what is called prodromal Parkinson's disease. And these non-motor symptoms may become more prevalent and obvious over the course of the illness, but they're also present to a variable degree throughout all stages of the disease and vary between individual to individual. So the progressive disability is really a combination of all these non-motor problems and the severity of the motor features. Also, not all these symptoms may be experienced by an individual patient. Um, some symptoms that I'd like to talk about here is REM sleep behavior disorder, which can often be a sign that somebody may end up developing Parkinson's disease. So we all often have dreams in sleep in what is called the REM stage, the rapid eye movement stage of sleep. And your muscles are inhibited during the REM stage of sleep. So you dream, but you don't really act your dreams out. Interestingly, patients with RBD or REM sleep behavior disorder tend to act their dream content. Now, this might be subtle, but sometimes it can be quite dramatic, where somebody might fall out of their bed or end up, hitting their bed partner or dog inadvertently. And so, bedroom safety is quite important if somebody has this. Um, Patients can have issues with mental health even earlier on, or may see an increased severity of depression or anxiety, which are common problems in patients with Parkinson's. Hyposmia is a reduction or loss of smell for unclear reasons, which can be seen in certain neurodegenerative condition like Parkinson's and Alzheimer's disease. Parkinson's also affects other systems of the body, such as the bladder and the blood vessels, causing dizziness when one stands. And in time, Parkinson's can also lead to Parkinson's psychosis, which manifests with delusions and hallucinations. There really is a spectrum to these hallucinations. So this might start off insidiously by the awareness or presence of shadows or seeing, critters, bugs on the floor. In time, patients may have illusions where objects may appear differently. So the shower curtain may look like a waterfall, or um, a branch of a tree might look like a person's arm reaching out through the window at night. And then there's, the end of the spectrum, which is more florid visual hallucinations. Interestingly, the hallucinations of Parkinson's patients always report that, they tend to keep to themselves. They don't necessarily interact much with them, but they tend to be an intrusion on their privacy. And again, not everybody develops, all of these symptoms. We'll get to some of these motor complications like fluctuations and dyskinesias in a bit. But besides these cardinal motor features, there's also a significant impairment of balance and gait, which can result in falls. And so it's important to recognize this early on and develop strategies to improve balance and reduce the risk of falls. Now, Parkinson's disease is clinically diagnosed with motor abnormalities, which are central to the diagnosis. So the motor features that we look for when a patient comes to clinic is something called bradykinesia. Bradykinesia is really the slowness of movement, but it's much more than slowness. It's also the inability to sustain the same range of repetitive motion. So what I mean by that is one way of measuring bradykinesia is with finger taps in clinic. Patients with Parkinson's may find that the taps become smaller the more they do it, or there may be interruptions or slowness in these taps. In addition to bradykinesia, which is required for the diagnosis, patients may have either rigidity or a rest tremor or both. So rigidity is really the tension in the muscle. So imagine a string. The string is loose. You don't really feel much tension in it. However, if it's stretched tightly, it's more taut. And so stiffness in the limbs is another characteristic feature. Rest tremor seems to be a pretty characteristic feature of Parkinson's. This is when a hand is at rest and is supported. There might be the presence of a tremor, and it's usually unilateral, which means it starts on one side of the body before slowly progressing to the other side. Now, for clinically established Parkinson's, which means the degree of certainty that somebody has it is at least 90%, it's also good to have at least two of these supportive features. So one is a beneficial response to dopamine treatments, to dopaminergic therapy. The other ones are levodopa-induced dyskinesia, which we'll talk about in a bit, the rest tremor of a limb, and olfactory loss, which is poor smell, or the cardiac denervation on an MIBG scan, which is again a marker of reduced innervation of the heart by the autonomic nervous system. It's also important that there be no red flags. Red flags are clinical signs or features that are present in a person that usually indicate another diagnosis, another kind of Parkinsonian condition. Now, you don't really need a scan or another test per se to diagnose Parkinson's, because it is diagnosed by the story and the physical exam findings that uh, the neurologist performs in clinic or the medical professional performs. But the way we've been diagnosing Parkinson's is with these motor features, and in the 21st century. And we've seen all these non-motor symptoms that can kind of precede the onset even. And so the field is now evolving towards a more biological based definition and staging of Parkinson's based on somebody's gene status, tissue biomarkers, which are based on the detection of a insoluble protein called alpha-synuclein, and neuroimaging biomarkers, which are tests which look at the dopaminergic system, such as the use of a DAT scan or a dopamine transporter scan. Now, these additional tests, such as a skin biopsy for synuclein or a DAT scan, can be useful in some cases where there might be a bit of confusion about the diagnosis, but they're not really required to make a diagnosis of Parkinson's. Now, with this concepts in mind about what Parkinson's might be, the question is what leads to Parkinson's disease, which the answer to which remains elusive. So Parkinson's is in an individual. It arises from a complex interaction between aging, genetic, and environmental risk factors. So these environmental risk factors involve pesticides, herbicides such as Agent Orange, which was widely used in the Vietnam War, organic solvents and dry cleaning agents such as trichloroethylene, and even air pollution. And this environmental risk is really cumulative with exposure across one's lifespan. Now, when it comes to genetics, inherited genes account for maybe only 5 to 15% of Parkinson's cases around the world. So if somebody in a family has Parkinson's disease without other family members having it, I usually counsel them that this does not necessarily confer a significant likelihood of other people in the family developing Parkinson's disease. Coming to the pathology, over here you see different tissue sections from the brains of patients. So this tissue is focused on a part of the brain called the substantia nigra, literally meaning black substance. This is a brain region which is really rich in dopamine, and the substantia nigra is part of the basal ganglia. The basal ganglia are brain structures which regulate voluntary movements and are involved in learning and habit formation. They also play a role in emotion and thinking and memory. The middle panel here is that from a section from a patient with Parkinson's, which shows the presence of what are called Lewy bodies. These are inclusion bodies which develop within the brain cells of patients with Parkinson's, and they're rich in a protein called alpha-synuclein, which, when insoluble, accumulates as these Lewy bodies. So here you see an immunostain against alpha-synuclein staining positive for it. Now, alpha-synuclein is actually a protein which is abundant in the brain, and it's found mainly in the terminals, the endings of neurons. It's believed that it plays a role in neurotransmitter release between neurons, and so helps facilitate the communication between different neurons. In Parkinson's, the alpha-synuclein tends to accumulate and forms these insoluble inclusion bodies called Lewy bodies. Now, it remains unclear if what this Lewy body is. Is it a cause or consequence of the degeneration of cells? And this is because Parkinson's, in a few cases, can also exist without the presence of Lewy bodies. There can also be patients who have incidentally Lewy bodies in their brains without actually developing Parkinson's. And so these concepts have led to questioning the fundamental role of the Lewy body in Parkinson's disease. This Lewy pathology also is not just restricted to the brain, but appears to also be in the peripheral nervous system, the spinal cord, the gut, and the skin. This seems like a busy slide here, but it's kind of looking at the cartoons are looking at what's really happening at a cellular level in Parkinson's disease. So the mitochondria are the energy batteries of the cell, and they're really involved in determining whether a cell survives or whether it undergoes damage. Now, mitochondrial dysfunction and synaptic dysfunction are early events in the pathogenesis of Parkinson's. So alpha-synuclein we just saw is something that's involved in this cell signaling process. And whenever there's alterations in synaptic function and mitochondrial damage, there leads to an increased production of reactive oxygen species and increased calcium levels within the cell. All of these are toxic to the cell. Further, alpha-synuclein in general is cleared by lysosomes, which are, can be thought of as the trash bin within the cell. And this increased turnover of alpha-synuclein, where the cell is unable to clear it, leads to, increased cellular levels of these toxins and its subsequent aggregation. Further, there also tends to be inflammation in general, not just in the brain, but also in the periphery here. In fact, studies show a low-grade elevation of inflammatory cytokines, and more inflammation has been linked to more rapid disease progression. There's also been recognition that the gut flora, the microbiome in patients who have Parkinson's may be slightly altered with a shift towards bacteria or species that produce more toxins compared to short-chain fatty acids, which are the healthy chemicals. And this can be linked to further alpha-synuclein aggregation and brain pathology in Parkinson's. Now, by the time somebody develops a tremor, there's already about 50 to 70% loss of the cells which make dopamine in the substantia nigra, suggesting again that this disease process begins well in advance, and these symptoms are experienced once a critical threshold is met. But the good news is that despite this degree of dopaminergic deficit, restoration of dopamine levels in the brain can be quite effective. In fact, I recall my mentor, Dr. Standard, mentioning that it continues to amaze him daily that just flooding the brain back with dopamine when taken as a tablet, even in a non-physiological way, can really improve motor function in most cases. And this levodopa has been the gold standard of treatment for over 50 years and is going to continue to remain the cornerstone of therapy. Levodopa is absorbed after the gut in the small intestine, and then eventually penetrates the blood-brain barrier and enters the brain, where it gets converted to dopamine and improves motor symptoms. So the transit and absorption of levodopa from the gut is another factor which influences its availability in the body. And here we'll just try to understand these concepts of on time and off time. So levodopa, which is the active ingredient in Cinemet, for instance, or carbidopa levodopa, is something which has a short half-life. So over time, with disease progression, a patient who may have been able to get by with one tablet every 6 or 8 hours finds that the medication may not last as long, and they may wear off before their next dose. So in the off state, somebody may experience more tremor, more slowness, and more stiffness. And this can be particularly troublesome as this therapeutic window narrows. Over time, there's also other features which what are called motor fluctuations, where the medication may not kick in as soon, so patients may end up spending more time in an off state with a delayed on time. Patients may also have end of dose wearing off, where the medication just doesn't last to the next interval, or they may have dose failures where the medication never kick in. So ideally, you want a patient in an on state for as much as possible with minimal off time. The other side of the spectrum is something called dyskinesias. Levodopa-induced dyskinesias we saw as one of the supportive features. In fact, it's a marker of success. It tells you that the levodopa is doing its job, except perhaps it's doing it too well. So dyskinesias are involuntary movements. These are patients who find it hard to sit still. They may experience twitching or twirling or fidgety kind of movements. And in general, the experience of patients is that they would rather be on with a bearable amount of dyskinesia rather than be off. And several studies have shown that it is not right to delay therapy because of the fear of dyskinesias. In fact, delaying therapy with levodopa could have short-term negative effects on a patient's quality of life. And so it's important to have this discussion and with your doctor, and early initiation of levodopa must be considered in most cases where it's warranted. And now with time, there have been developments in levodopa formulations and also other standardization of other techniques, such as deep brain stimulation, which have substantially improved the life of patients with Parkinson's. And as a result of all of these developments, Parkinson's is now a chronic disease, and it is quite possible to live well with this disease. So when we talk about dopaminergic therapy, we're talking about uh, chemicals which modulate this dopaminergic system in our body, which kind of helps us move better. But it can also have some effects on cognition, where it can help a patient think clearly, etc. So levodopa in general is combined with a peripheral inhibitor, such as carbidopa or benserosid. And this is to prevent its common side effects and allow more of it to penetrate the blood-brain barrier and enter the brain. So the common side effects of carbidopa levodopa is nausea, vomiting, or dizziness. And so when a patient gets started on the medication, it's very important to start with small doses and then titrate up slowly as tolerated. There are certain adjuncts to this carbidopa levodopa, such as the COMT inhibitors, entacapone, tolcapone, more recently opicapone, and also the MAO-B inhibitors in the brain, like rasagiline, selegiline, and sulfonamide. These are really enzyme inhibitors and help make the levodopa last longer, prevent it or reduce its degradation by enzymes. Another way to improve things is to just directly stimulate the dopamine receptors in the brain. So this is where dopamine agonists like pramipexole, ropinirole, apomorphine, and rotigotine come into play. However, it's quite important to note the side effect profile of the dopamine agonists, which can be quite troublesome in patients. So common side effects are drowsiness or sleep attacks. Some patients may have an irresistible urge to fall asleep with this, swelling of the peripheral extremities, such as the limbs, hallucinations, and impulse control disorders. So these are uncontrollable urges, which can lead to compulsive tendencies like excessive shopping, spending money gambling, hypersexual drives, or binge eating. It's always important to kind of monitor these symptoms and see if there's a side effect associated with these medications. Now, more recently, we have sustained release formulations of levodopa, as well as continuous delivery systems to address the problem of the motor fluctuations and dyskinesias in patients with advancing PD. So these are extended release capsules, IPX066 or Rytary in the United States, Crexont more recently for this purpose. And then the delivery of levodopa directly to the absorption site in the gut by the form of an intestinal gel. More recently, Vyalev is a subcutaneous delivery of levodopa. This can be thought of as analogous to an insulin pump in somebody with diabetes, for instance. It goes in the belly, around the belly button. And so far, we've been really discussing this pharmacotherapy, focusing on dopamine, but it's important to note that there are reduced levels of other neurotransmitters as well, such as serotonin and norepinephrine in the brains of Parkinson's patients. And I've also not discussed the treatment options for the non-motor symptoms in this short presentation, but it is important that if you're a patient or a caregiver, you're cognizant of these problems and bring this up with your physician, as the burden of the non-motor symptoms can be quite significant. We've seen the effect of chemical modulation on the brain. Another powerful tool that has been at our disposal for close to 3 decades now is neuromodulation. So this is basically electrical stimulation of targets in the basal ganglia, which control motor function. So DBS has broad effects on neural networks, and by modulating these feedback loops, it can typically improve motor symptoms, such as a difficult to control tremor or speed and stiffness. And it allows patients to really move better and achieve their goals. So the lead for deep brain stimulation is this electrode lead, which is implanted in either a part of the brain called the subthalamic nucleus or the globus pallidus. It passes through a borehole in the skull. And attached to the lead is a wire which snakes its way, tunnels under the skin of the scalp, and attaches to a battery, the pulse generator. So this can be thought of as a pacemaker for the brain. Now, not everybody is a great candidate for DBS. So again, it's important to assess patients who are right for this treatment where the benefits outweigh the risk profile. So in the last 3 decades, which really, if you think about it, is just 10% of the time since the first seminal description of the disease by James Parkinson's, there have been several advances in our understanding of the biology of the disease and an improvement in these therapeutic strategies. And due to all of this, Parkinson's is now a chronic disease. But a point to note is that all these treatments so far improve symptoms, but we still don't have a cure for this disease. So it's very important that all symptomatic treatments, which is medications and possibly surgical treatments, be combined with wellness practices if living well with Parkinson's is a desired goal. So Oliver Sacks, that brilliant writer who could so very well communicate the patient experience, talked about the role of music and gardens in neurological diseases. If he was still alive and practicing today and was seeing patients with Parkinson's, he would also probably talk about exercise, diet, and the importance of a daily routine that fosters a wellness lifestyle that allows patients to take control of their disease. So if you take away anything from this talk, let it be this slide, which is focusing on exercise. And that's because it is fundamental for Parkinson's disease. And there's several lines of evidence from animal models in human studies and long-term studies of Parkinson's, which support the fact that it can slow down the disease progression. It's also fundamental for aging well in general. So exercise enhances neuroplasticity, which is the brain's ability to form new connections. It increases levels of BDNF and GDNF. These are growth factors, which are important for the survival of dopamine neurons. It helps you leverage dopamine better and improves mobility and balance. Exercise also improves sleep. It improves cognition and mood, all of which can be affected in Parkinson's. And a recent Cochrane review, which is basically an analysis of several different clinical trials, found that most exercise types were really beneficial for Parkinson's, with a slightly superior effect of dance. But in general, I encourage patients to find a good exercise strategy that works for them, which is accessible, and to try to do it as frequently as possible. So exercise is medicine. It should be prioritized and prescribed and taken daily. The goal of 150 minutes really comes from the American College of Cardiology guidelines. So this is 30 minutes of moderate to vigorous exercise, at least 5 times a week. My personal view is that it's probably best to also incorporate about 1 or 2 active rest days, focusing on a stretching or a mobility routine such as yoga to just improve core strength and reduce injuries. Now, the activities, exercise activities, ideally should be elevating your heart rate and involving large muscle groups. So you get this from aerobic and also resistance training. Patients with Parkinson's might find that it's easier, it's better to exercise during the on times when the medication is really kicked in and flowing. So it's good to see if you can prioritize your time of the day for exercise during then. Off times and wearing off tends to be more common in the evenings. So adjusting your day accordingly works better for some folks. And working with physical therapists or trainers who specialize in Parkinson's can be really helpful. It's often hard to do everything, be self-motivated every day. So having an exercise buddy to keep you accountable and fun, is always suggested. There's several group exercise classes. Rocksteady Boxing, for instance, is one such class, which a lot of patients with Parkinson's enjoy. Fencing your calendar. So this is a strategy that Jerry Seinfeld adopts. So when asked about how he was so successful as a comic, he mentioned about writing 1 original joke a day. And whenever he does that, he puts an X on his calendar. And he's been basically fencing his calendar without interruptions for several years now. Goes to show again how positive feedback loops can really encourage us to have a discipline of a good practice. And also, while it's important to stay active and do household chores and yard work, these are activities and they don't really give you the benefits that exercise can give you. In addition to exercise, a combination of a good diet, good sleep, and mental health is extremely important because this can also be very helpful for cognition. So, a diet focused on a whole food plant-based diet or the Mediterranean diet can be extremely helpful for Parkinson's, particularly in those that have constipation and issues related with the gut. There can also be a role of probiotics, which can significantly help these issues. It is important to have a good winding down routine that is focused on improving the quality and quantity of sleep. A lot of patients feel like sleep recharges their batteries. In fact, if possible, I suggest a small afternoon nap for no longer than 30 minutes can be equivalent to as much as half a tablet of carbidopa levodopa in some patients. It kind of really energizes them and helps them get going for the rest of the day. And sleep in general has a lot of good positive benefits to the brain. And with all of this said, mental health is extremely important. Viewing Parkinson's, it's not just a disease which affects you physically, but also mentally. And having the right mindset is extremely important. I think meditation can be an incredibly powerful tool when done well and done right, and done for prolonged periods of time. In fact, there's been interesting studies on how long-term meditators looking at Tibetan Buddhist monks, they have preserved gray matter volumes in their frontal cortex, which is as good as a healthy 20-year-old individual. So the frontal cortex is that part of the brain which helps you think and make decisions. And so it's quite interesting how your thoughts can also rewire and really restructure your brain. Besides this, cognitive behavioral therapy for those that have anxiety, depression, or apathy can be an incredibly powerful tool. Social networks, it's important to maintain good relationships and not isolate yourself. We're creatures that live in societies, and community can be an incredibly powerful thing for people and families with Parkinson's disease. Um, there is meaning in creative pursuits in things like music, reading, and art, which stimulate the brain. And I personally find that activities like journaling or taking a hike in nature can be really good for one's mental health. So this was a very nice case report recently in the Movement Disorders Journal, but it should be available for people to read even on PubMed. So this case is a history of Miss Anna Hellevick, who's also one of the authors, who is the patient in this. And it's a powerful example of the value of self-care in someone with Parkinson's disease. So she's a 60-year-old woman with clinically established Parkinson's disease who's been able to reduce Parkinson's medications and improve her symptoms without much progression, with a combination of intensive meditation, exercise, which involves a dance practice and a diet routine. And so this case of the dopamine dancer also illustrates how in some individuals, the extent of improvement that can be achieved by self-motivation and hopefulness can be a great thing. Now, there's increasing evidence that the management of Parkinson's must encompass a multidisciplinary approach. And the notion that it's a neurologist alone who's the key player is no longer the case. So this is a nice figure from the Lancet where the authors make the analogy of the Parkinson's patient being the sun and various professionals revolving to deliver support. So there's no individual stars in a multidisciplinary team. And across different stages of the disease, different symptoms may need expertise and management from professionals beyond a neurologist. And so it is important to discuss and seek these individuals or therapies out. So in his book, The Obstacle is the Way, which was influenced by the writings of the Roman Emperor Marcus Aurelius, Ryan Holiday talks about the obstacle in the path becoming the path. To never forget that within every obstacle is an opportunity to improve our condition. And I'm really inspired every day by the resilience of somebody living with Parkinson's, and how far one's mindset can really contribute to improving one's physical condition. So Parkinson's disease, we've seen, is a very complex and progressive multi-systemic disorder. It has different subtypes and is really experienced uniquely by every patient. It is caused by a complex interaction between aging, genetic, and environmental influences across one's lifetime. It's important that it be diagnosed early and therapeutic interventions be done early, so symptomatic improvement and enhanced quality of life may be achieved. And exercise and daily wellness practices are critical to slow down disease progression. These are some resources. So if you or a loved one has Parkinson's, I think it's very important to establish care with a movement disorders neurologist. So these are healthcare professionals who've done a residency in neurology, and then in the United States have done 1 to 2 years of fellowship training focusing on Parkinson's and other movement disorders. Um, Rocksteady Boxing, I've just put a link there where you can find a class. This is probably there in most states across the US. The Parkinson's Foundation has a really good helpline, which you can call to ask any questions about the disease or other things related to its management. It's also a good helpline to connect you with resources in your geographical location. Clinical research is incredibly important. We've been coming up with better strategies to treat the disease, but there's still a lot of hope for a cure. And so I encourage patients with Parkinson's to always consider involvement in clinical research and clinical trials. The Fox Trial Finder on the Michael J. Fox website is a good place to look at that. And there is power in numbers, there's power in stories, and we can all learn from each other's experience. So I encourage patients to consider joining a local Parkinson's support group or a state chapter. So that's our team, our movement disorders division here at the University of Arkansas in Little Rock, and that's my own personal team there, getting some sunshine in the natural state. And thank you. Thank you for your attention.
Thank you, Dr. Boddu. I want to acknowledge the skill that you just shared with our community here on what I started with the webinar saying. This is a simple and basic overview of Parkinson's disease, and what you have shown us is that this is not simple. It's not basic, and there's lots to learn about Parkinson's, and there's so many resources that we can tap into to live a life well with Parkinson's disease. So thank you for illuminating that for all of us.
Thank you.
We have lots of questions, and would love to, we could make it a dialogue format, and want to acknowledge that so many of us here today have some questions to get through. So Dr. Boddu, I'd like to ask, one of our members today, Bob, is asking, what percentage of Parkinson's has a familial link versus an idiopathic connection?
Yeah, so the number really also varies based on different epidemiological data. So there seems to be certain clusters or hotspots across the world where Parkinson's may be seen in small communities or families. That being said, the overall genetic influence on Parkinson's tends to be about 5 to 15%. If I come across a patient who says that there's multiple generations in his or her family where there has been Parkinson's, then I'm usually suspicious for a genetic link. That being said, most patients do not develop Parkinson's because of a single gene. Recent studies, genome-wide association studies, look at certain signals in one's genetic architecture, which can increase or decrease your risk for Parkinson's. And so there's been some understanding of certain sections of our DNA or genetics that can influence that. But overall, Parkinson's doesn't seem to be a genetic disease, if that helps answer the question.
Yes, it does. Thank you, Dr. Boddu. And the Parkinson's Foundation is doing a clinical trial on genetics and Parkinson's to help us understand the relationship between the risk of manifesting Parkinson's disease and not. So I'll ask Laura to put some information in the chat for you all to look into our PD generation study if you're interested in contributing to science and advancing research. Along the lines of risk, right? We're talking about genetics here. Toby shares or writes in, the environmental factors are characterized as either increasing or decreasing the risk of Parkinson's. Are all of these considered risk factors to some extent, just in different directions?
Yeah, so it's exactly as you said. So there's positive environmental, factors. There's negative factors which increase your risk of getting the disease. So when we think of, really the larger environmental risk factor, there's been a lot of understanding that environmental toxins, which are present in pesticides or herbicides, for instance, which are, often seen in farming communities, can significantly impact the dopaminergic system in the brain and can increase one's risk for Parkinson's. One There've been studies which have recently looked at the exposure with environmental toxins in the water at veterans who are at Camp Lejeune. So we do know that there's certain environmental toxins that could increase one risk for Parkinson's. I think the idea that Parkinson's could be caused by an environmental agent came in the late 80s or early 90s, when it was found that in Southern California, certain heroin addicts tended to have the features of Parkinson's disease, and they were able to isolate an agent which was used, which the heroin was laced with. So that was the first indicator that an environmental toxin can, profoundly impact the brain and cause Parkinson's disease. In fact, MPTP is that chemical which is used to experimentally create Parkinson's in mice, in animal models of Parkinson's. When it comes to positive things or risk factors which reduce your risk for Parkinson's, there have been some interesting studies on the association of caffeine and smoking. So caffeine seems to be conferring a positive benefit. I advocate for a cup or two of coffee a day. It really helps you focus and improve clarity and power through your day. It's interesting also about smoking, right? So there seems to be a reduced risk of Parkinson's in smokers. That being said, smoking is not good, and you're probably gonna suffer from something else like cancer or heart disease while trying to reduce your risk of Parkinson's. But yeah, there's an increased understanding of all these other, agents that can, along with genetics and aging, potentially lead to Parkinson's in an individual.
You hit the second part of Toby's questions, was if should we consider avoiding the behaviors like smoking, drinking coffee or alcohol, or using NSAIDs, even though they're associated with a risk of Parkinson's?
Yeah, so it's hard to individualize this to one single patient, but in general, I think, we should not be smoking or vaping. As far as coffee goes, I think coffee in general is good for cognition and brain health. And then NSAIDs, the long-term use of NSAIDs can have its own impact on systems such as the gut and the kidneys. So currently, there's no recommendation that one begin taking, NSAIDs on a daily basis if they have Parkinson's disease.
Okay. Thank you for clarifying that. I recently stopped drinking coffee, and I might just reindulge. We got a question about the use of carbidopa levodopa and its ineffectiveness on symptoms. So one of our community members is asking, if I take prescribed medication, the carbidopa levodopa, for a few months and it does not have an effect, what does that mean? And then they go on to ask, is the Parkinson's diagnosis still valid?
Yeah, so that's a good question. Now, most patients respond quite well to carbidopa levodopa. That being said, it's also a matter of timing. So in my practice, I generally tend to start somebody on a very small dose, like just a half a tablet a day, and I slowly, incrementally increase it. So it takes at least about 6 weeks. But in general, I tell patients to give it at least 6 to 12 weeks, that is at least 1 to 3 months, to really see the impact of the carbidopa levodopa on one's symptoms. And that is because levodopa not just has a short duration effect, but also a long duration effect where it's kind of modifying, synaptic plasticity in the brain. Further, there's some symptoms such as the tremor, for instance. Most cases, tremor responds, but somebody can have Parkinson's disease and have a tremor that's very stubborn, that never responds to carbidopa levodopa. So that's an important thing to keep in mind and discuss with the doctor. And then, of course, there's the thing about the diagnosis. Again, we're assuming that the patient has met clinical, criteria, has the features of Parkinson's disease, but no response, even after prolonged use of carbidopa levodopa, should again raise suspicion for possibly another Parkinsonian condition. Another thing to keep in mind is how severe are the symptoms. If your symptoms are very mild, it may be hard to notice an effect on a mild symptom compared to more burden of symptoms where you notice a more, a higher delta, a more significant improvement. So I guess all these things may need to be considered.
Yeah, there's so many personal things that can influence the way that our body receives the carbidopa levodopa. So thank you for bringing that sort of perspective and on how we experience the impact of the medication. Still on the subject of medication, Jean is asking if we could speak to the myth of beginning levodopa because it will lose effectiveness. So slowing down the introduction of carbidopa levodopa therapy and its effectiveness over time.
Yeah, so unfortunately, there has been an era of levodopa sparing strategies, but a lot of clinical studies have shown that this led to under-treatment of patients. Head-to-head, levodopa tends to be more effective than a dopamine agonist. And while dopamine agonists may reduce dyskinesias, they may not be as effective as carbidopa levodopa alone to treat a motor symptom like slowness or stiffness, balance, or tremor. Yeah, the sparing of levodopa is not, a good notion. The fact is that dyskinesias are inevitable in about, 30 to 50% of patients with Parkinson's, and dyskinesias are a consequence of disease duration as well. So you need both Parkinson's disease and, the use of levodopa to develop dyskinesias. And this is again because these receptors in the brain are not receiving the natural inflow of dopamine. You're stimulating these receptors artificially in a pulsatile fashion every couple of hours by taking a drug which converts to dopamine. And that seems to be the cause for dyskinesias. But that strategy often, leads to under treatment of patients where, you avoid levodopa. And so it may not be the right one. In fact, studies have shown that earlier initiation of levodopa actually helps motor symptoms. So it's not that the levodopa becomes ineffective, but it's rather that the disease tends to progress. And the nature of the disease is one which involves these motor fluctuations, where there may be consideration for other levodopa formulations or other adjuncts.
Yeah. I wanted to follow up, Rosalind. I want to make sure I ask this question as we're on this subject. Do most people with Parkinson's experience problems with dopamine over time, like dyskinesias?
So the answer to this is really varied. So I've had patients who've never developed dyskinesias despite having good on time and having good treatment response. On the other hand, patients tend to develop dyskinesias, pretty soon after its introduction. This is commonly seen in females of younger females of a lower body mass as well. So it's important that again dosing be titrated according to one's BMI. So yes, you see patients with dyskinesias who never develop it. You also see patients who do develop it earlier on in the course of the disease. And with time, with disease duration, the motor fluctuations do tend to occur. But how and when that occurs is again very variable. I've had patients who've done quite well for a decade without having developed significant motor fluctuations on a reasonably modest dose of carbidopa levodopa.
I got a question from Norris, and thank you, Norris, for asking this. Dr. Boddu, could you explain what on means?
Yeah. So on is basically when somebody with Parkinson's may feel normal. So characterizing what normal is difficult, but a classic complaint of somebody with Parkinson's, for instance, is a tremor in one hand or a resting tremor. Another one is a cramping sensation or tightness in the body. So these would be off symptoms. When you take the medication begins to work and improve your motor symptoms. That would be classified as, an on time. So ideally, you want a patient to be in a good on time throughout the course of the day with, less off time because it's the off time that's bothersome. I like the analogy of one of my patients who said he feels like every day is a football game in 4 quarters, takes the medication 4 times a day, and he can tell when it's time for the next quarter because he wears off. In the period that he wears off, he tends to have a emergence back of his tremor and a little bit of slowness. Also, off times can manifest not just with motor symptoms, but non-motor symptoms. So a common symptom is that patients may feel sweating, or they may feel incredibly anxious. And when you ask further, it tends to correspond with their off times, where the medication is just not lasting until the next dose. So that's on and that's off.
Thank you for explaining how the fluctuation is in between both parts, right? You're on motor fluctuation, off motor fluctuation, and how the carbidopa levodopa can help us sustain more equilibrium between those fluctuations of on and off. You mentioned anxiety and the role that carbidopa levodopa may play in this invisible symptom of Parkinson's disease. So Glenn is asking, does carbidopa levodopa help with Parkinson's disease-induced anxiety and depression?
It can help in a few cases, particularly those cases where the anxiety tends to occur with those fluctuations. When the patients are off, they may feel a profound sense of panic or anxiety. So in those cases, trying to leverage dopamine better, have kind of that equilibrium, would be helpful. That being said, anxiety and depression are also often treated like you would treat other patients with anxiety. So you would use a combination of, SSRIs or SNRIs. So, these are medications such as Prozac or Zoloft. But then again, taking medication is good, but it might be a passive approach to anxiety, which is so environmental and state dependent. So often I ask patients to consider also cognitive behavioral therapy, or see a psychiatrist as well, that can help manage their anxiety better.
Yeah, I've heard, Dr. Boddu, and please correct me if my understanding is inaccurate, that the motor symptoms are less significant for a lot of people with Parkinson's than the non-motor symptoms, the non-movement symptoms. So speaking to the mental health side of Parkinson's, cognition and the changes in our mood and apathy and anxiety have much more of a significant impact on our daily living and quality of life than the movement symptoms do. Is that correct?
Yeah, no, you're exactly right. You hit all the points there. So the Priamo study, I think in 2009, looked at the burden of non-motor symptoms in patients in Italy, and these patients had more burden of symptoms, impairment of quality of life from the non-motor symptoms compared to the motor symptoms. And so it's again important to characterize what exactly is your symptom profile. I'm diagnosing you based on these motor symptoms, but underneath, like, what I'm seeing is probably the tip of the iceberg. So it's important to know the spectrum of non-motor symptoms. And again, it's also possible that somebody has very less non-motor symptoms compared to their motor symptom profile, but you're right, in general, it's the burden of the non-motor symptoms that can cause more issues with daily living.
So, my friends, keeping that in mind as we navigate this journey together, for those of you who are recently diagnosed or early onset Parkinson's disease, that there's much more that goes beyond what we can see in Parkinson's, and don't hesitate to find resources and people that you trust and can confide in to speak to these symptoms that we see beyond the surface. It's just being respectful of our time together, Dr. Boddu. We do have a few care partners here present with us, and one of our care partners is asking if you could touch on some things that a caregiver or a loved one or a friend or family member that might be supporting someone with Parkinson's, what they could do to help build a quality care team to support their person with Parkinson's.
Yeah, no, that's a great question. Really, the people and families living with Parkinson's are the experts, because you see this disease from such close quarters, and it impacts you on a daily basis. As a caregiver, I guess just knowledge and education of what Parkinson's is and the spectrum of disease, knowing what to look for, is important. And these often come through in conversations with other families and other people who have Parkinson's disease. So tapping into your local support groups and local networks can be a huge resource there. And also, as a caregiver, I think it's important to find time for yourself, because it can be challenging navigating this complex disease. And so taking care of yourself also and can enable you to also, support somebody with Parkinson's disease.
Great. Thank you, Dr. Boddu. Any final words you'd like to share before I close this out?
No, I'd just like to say again, thank you so much for this invitation to, just present my thoughts and hopefully expand on Parkinson's disease to the audience. And yeah, let's keep on carrying on, and happy to be here.
Thank you, Dr. Boddu, for offering your time and your knowledge for today's Wellness Wednesday webinar. I really appreciate the way that you created a presentation and delivered it in a way where we know now Parkinson's disease is not a simple disease to live with, and there's so many complexities behind it, and we're just scratching the surface. So thank you for giving us that introduction to Parkinson's disease in the way that you did. And a big thank you to each of you who joined us today. And thank you to our sponsor, Biogen, for supporting the mission of the Parkinson's Foundation. Before we wrap up, we have one last favor to ask of you. Your feedback is essential to shaping the Foundation's programming. As the webinar concludes, a survey will pop up on your screen. Please take a moment to share your thoughts and let us know what topics you'd like to see in future sessions. And thank you so much again for joining us today. We are honored to have shared this time with you and hope you found the information and resources helpful on your journey. Please know that you are not alone. Our community is here to support you every step of the way. Your strength, your resilience, and your dedication inspires us, and we are grateful for the opportunity to be a part of your journey. If you have any questions or need additional support, don't hesitate to reach out to us. Together, we can navigate this path and continue building a brighter future. Thank you again for being with us, and we look forward to connecting with you at future programs. Take care and be well.